Okay, so we're going to start chapters 7, 8, and 9 for the next 2 weeks. I'll try to distribute the lectures over those 2 weeks. I will distribute the lectures over those 2 weeks, and you'll have those 2 weeks to complete all these homework assignments. They all deal with bones and bone tissue. So let's start with chapter 7, bone tissue. The skeletal system is composed of bones, cartilages, ligaments joined that form a framework for the body. The study of bone is known as osteology, and cartilage is a forerunner for almost all the bones, and it covers many of the joint surfaces. Ligaments are holding the bones together at the joints, while tendons attach muscles to the bones. Some of the roles of the skeleton include support. Limb bones and vertebrae support the body. Jaw bones support our teeth. Some bones support the viscera. Many of the bones are there for protection. They completely surround the brain and pretty much surround the spinal cord, and many bones help protect the heart, lungs, and even other organs. They're involved in movement, as you know. They're going to serve as levers to manipulate the environment. They also play a role in breathing, and most movements will depend on a bone. Electrolyte balance, because of their calcium and phosphate content, can be regulated by using bone. An acid-base balance within the body. There are blood buffers that guard against large pH changes, and that could affect the phosphate and carbonate levels. Bones are where blood is formed, and there are some hormones secreted by bone cells. That might affect the action of insulin, and others are involved in a stress response. Osseous tissue or bone is a connective tissue where the matrix is hardened by calcium, phosphate, and other minerals. That process of mineralization, or calcification as it's sometimes referred to, happens in individual bones. Each one of those individual bones you can think of as a distinct organ. It has more than one type of tissue in it. There's bone tissue, bone marrow, cartilage, adipose tissue, nervous tissue, and fibrous connective tissue. So when we use the word bone, we may be referring to the organ or just the osseous tissue. In general, I use the word bone to refer to the organ. There are a variety of bone shapes. Some bones are flat bones, which are thin, curved plates, and many of those work to protect soft organs. For example, the parietal bones of the skull, the sternum, the scapula, ribs, and hip bones. There are long bones. Long bones refers to a bone that is longer than it is wide. It really doesn't have to do anything with its overall length. You can have short, long bones, but they're going to be longer than they are wide. They tend to be rigid levers that are acted upon by the muscles, and they are crucial for movement. Our humerus, our radius, our ulnus, femur, and so on. Some bones don't fit into those categories. When we do have what we call short bones, they are approximately cubed. They're about equal length and width. And the bones in our wrist and ankles are referred to as short bones. They're not longer than they are wide. Irregular bones have elaborate shapes, and the vertebrae would be the best example of those. A long bone has some general features. There is a compact, also known as dense or cortical bone, that makes the outer shell. That encloses the medullary cavity or the marrow space. There is spongy or calcaneous bone, which is loosely organized bone tissue. These are found in the center ends and the center shafts of long bones, in the middle of nearly all other bones. They're generally covered by a more durable, compact bone. So the skeleton in general is about 3/4 compact and 1/4 spongy bone by weight. But most bones, the organ of bone, will have combinations of compact and spongy. In a long bone, we have a shaft called the diaphysis, and at one end we have the epiphysis, which is an enlarged end. It strengthens the joint and anchors the ligaments and tendons. There's a proximal and distal epiphyses. And Associated with those epiphyses is an epiphyseal line. When someone is still growing, that's a growth zone, and it's known as an epiphyseal plate. When it completely calcifies, it leaves a remnant called the epiphyseal line. Articulate cartilage is a layer of hyaline cartilage that covers the joint surface, allowing the joint to move more freely. There are also nutrient foramina, which are minute holes in the bone surface that allow blood vessels to penetrate. The outside of that bone is covered with an external sheath known as a periosteum, the outer fibrous layer of collagen, and an inner osteogenic layer of bone-forming cells. There are also perforating fibers of the periosteum that will go into the underlying matrix of the bone. And endosteum is a thin layer of reticular connective tissue that lines the marrow cavity and the other internal bone surfaces. Flat bones have more of a sandwich-like structure. They have an inner and outer table. Those are the compact bones that you can see inside and outside, and a spongy bone layer in between. And in the cranium, it's specifically referred to as the dipole. So here's a typical long bone, spongy bone in the epiphyses, compact bone along the outside. Articulate cartilage, red marrow because blood is being produced in that marrow, and that's opposed to yellow marrow, which is primarily for fat storage. Flat bone, we have two layers of compact bone, spongy bone in the middle. There are four major types of bone cells. There are osteogenic cells, which are stem cells found in the endosteum and the inner layer of the periosteum. They arise from embryonic mesenchyme. They can multiply continuously, and they can differentiate to become an osteoblast. An osteoblast is a bone-forming cell in the endosteum, in the inner layer of the periosteum. It has the ability to do osteogenesis, which is to synthesize the soft organic matter of the matrix and promote its mineralization. Stresses stimulate osteogenic cells to multiply rapidly and increase the number of osteoblasts, which will reinforce bones in that area where stress is occurring. Osteocytes are fully matured osteoblasts. They can become trapped within the matrix they've deposited in a region called the lacunae, which is connected to the rest of the nutrients by structures called canaliculi. They are the cytoplasmic processes of osteocytes reach into the caniculi and contact the neighboring cells. There may be gap junctions which allow for the passage of nutrients, wastes, and signals. Some osteocytes reabsorb bone matrix, others are depositing in it. They are acting as strain sensors, so when a bone is stressed, it produces biochemical signals that help remodel, reshape the bone to make that shape and density adaptive to the stresses that it's under. Osteoblasts and osteocytes secrete a hormone called osteocalcin, which is part of an acute stress response. It stimulates the pancreatic secretion of insulin, increases insulin sensitivity, and promotes energy availability. Osteoclasts are bone-dissolving cells. They're found on the surface of bones. They perform osteolysis, which is the breakdown of a bone, as part of remodeling. They develop from the same bone marrow stem cells that give rise to blood cells. They're different origin than other bone cells. These are very large cells formed from the fusion of several stem cells. They have multiple, 3 to 4, maybe up to 50 nuclei in each cell. They have infoldings that increase the surface area, form a ruffled border that faces the bone, and they often reside in pits called reabsorption bays as they etch into the bone surface. The matrix is composed of osseous tissue. By dry weight, it averages 1/3 organic and 2/3 inorganic matter. The organic matter, which is synthesized by the osteoblasts, are collagen and carbohydrate protein complexes. Inorganic matter, the mineral component, is about 85% hydroxyapatite, which is a crystallized calcium phosphate salt, and 10% calcium carbonate, along with many other inorganic ions. Combination forms a composite material that provides both strength and flexibility, and you need to remember that when you look at bones in the lab. They have lost their flexibility. Collagen and minerals of bone form a composite material providing, again, flexibility and strength. That mineral portion allows the bone to support body weight without sagging, although a disease known as rickets is caused by a mineral deficiency that leads to deformed bones. The protein gives some flexibility. Those collagen molecules contain sacrificial bonds that will break under the stress and dissipate under load. There is another disease called osteogenesis imperfecta, often referred to as brittle bone disease, that results from a defect in collagen deposition. Compact bone is made with concentric lamellae. They're layers that surround a central canal. The central canal is traditionally referred to as the Haversian canal that would run longitudinally in the bone. A central canal and its lamellae constitute an osteon, or a Haversian system. Central canals are connected by transverse perforating canals. Collagen corkscrews down each lamellae. There's a helical arrangement, and one lamella is opposite to the adjacent one, and this enhances strength. Osteons are separated by a cement line, which would prevent the spread of microfractures. There's a circumferential lamellae found encircling the outer region of dense bone, and there are interstitial lamellae that fill irregular regions between osteons. Spongy bone, on the other hand, is a lattice of almost bone slivers called spicules and plates or trabeculae. They're all covered with endosteum. Gives them a sponge-like appearance, as you might recall from an earlier image. Spaces here are filled with red bone marrow. The matrix arranged in lamellae, but there are few osteons and no central canals. All osteocytes remain close to the bone marrow. This is going to provide strength with minimal weight. And you can see the stress lines, which correspond to the laying down of this bone. Bone marrow is a soft tissue occupying the marrow cavities of long bones and small spaces of spongy bone. It comes in two types: red bone marrow, which is myeloid tissue, which are multiple tissues, but they have hematopoietic tissues in them. They have the stem cells that will become all of the blood cells that we have. Almost all of the bones in early childhood contain red marrow. As we become adults, this red marrow shifts to some of the spongy bones, such as that found in the skull, the vertebrae, the ribs, the sternum, the pelvis, as well as the proximal head of the humerus and femur. Yellow bone marrow is replacing the red marrow in the marrow cavities of long bones. In adults, it's a fatty marrow that doesn't produce blood. However, it can transform back to red marrow if there is a chronic anemia. The development of bone is called ossification or osteogenesis. Bone develops by two methods. Both begin with an embryonic mesenchyme. The two methods are to have an intramembranous ossification, or most bones, an endochondral ossification. In an intramembranous ossification, we get flat bones of the skull, the clavicle, and parts of the mandible. So here, the model that's being used is found between two membranes. So we get the deposition of osteoid tissue into embryonic mesenchyme. the calcification of the osteoid tissue and the entrapment of the osteocytes. This creates a honeycomb of spongy bone with a developing periosteum, filling of the space to form compact bone at the surfaces, leaving the spongy bone in the middle. Intermembranous ossification, also important in lifelong thickening and remodeling of the long bones. So here we have the intramembranous ossification. Osteoid tissue begins to build, becomes entrapped between two cavities, and we end up with our honeycomb-like structure. Whoops. Until finally we get the bone. Most of our bone develops from not membrane model, but a hyaline cartilage model. Here, the mesenchyme forms early hyaline cartilage model, the formation of primary ossification centers, a bony collar, and periosteum. We get vascular invasion, formation of primary marrow cavity, and the appearance of secondary ossification centers. Bone at birth contains an enlarged marrow cavity and secondary marrow cavity in one epiphyses. Bone of a child will contain an epiphyseal plate, a growth plate, and the adult bone will have a single marrow cavity, and the epiphyseal plate will close and become the epiphyseal line. So we start with a bone made of cartilage, which provides the basic shape. Then bone cells, ossification begins to form the bone itself. And while we are still growing, we have the epiphyseal plate, which allows for increase in length. And becoming an adult, that calcifies and becomes the epiphyseal line. So here is a fetal skeleton at 12 weeks. We can see intramembranous ossification going on in the skull, and cartilage, endochondral formation in the other bones. Ossification continues throughout life with growth and remodeling of the bones. Bone elongation we have the epiphyseal plate. It serves as a growth zone. There's a transitional zone on each side where cartilage is being replaced by bone, called the metaphysis. The structure of the metaphysis corresponds to the steps of cartilage replacement. So there is a zone of reserve cartilage, a zone of cell proliferation, a zone of cell hypertrophy, a zone of calcification, and a zone of bone deposition. You can see the X-ray of a child's hand. As we get taller, chondrocyte multiplication in zone 2 and hypertrophy in zone 3 push zones of reserve cartilage towards the end of the bone, and as such the bone elongates. The cartilage growth from within is called interstitial growth. Cartilage of the epiphyseal plate is depleted by late teens and early 20s, and our primary and secondary marrow cavities will unite into one cavity. The junction is filled with spongy bone. And once again, that epiphyseal plate has been replaced by an epiphyseal line. An achondroplagic dwarf, the long bones stop growing in childhood. This results in a normal proportioned torso with short limbs. Happens because of a failure of cartilage to grow within the metaphysis. It's a spontaneous mutation in most cases, but that mutation creates a dominant allele. It is different than pituitary dwarfism. In pituitary dwarfism, we don't have growth hormone, and all of the structures are normal proportions, but short stature. Bone also gets wider and thicker as it grows. This is called appositional growth. Deposition of new tissue at the bone surface occurs by intramembranous ossification at the bone surface. So the osteoblasts of the inner layer of the periosteum will deposit osteoid tissue and become trapped as tissue calcifies. It will lay down matrix in layers parallel to the surface, forming a circumferential lamellae, and osteoclasts of the endosteum will enlarge the marrow cavity. Bone is continually remodeled, absorbed, and deposited throughout life, about 10% of the skeleton per year. We get repairs and microfractures. We will release minerals into the blood when needed. Wolff's Law of Bone says that architecture of the bone is determined by the mechanical stresses placed on it. So remodeling is a collaborative, precise action of osteoblasts and osteoclasts. Bony processes grow in response to mechanical stresses. Mineral deposition or mineralization occurs when it is the crystallization process in which calcium, phosphate, and other ions are taken from the bone and deposited in the bone. Osteoblasts produce collagen fibers that spiral the length of the osteon. Fibers become encrusted with the minerals. First few crystals act as seed crystals, and that attracts more calcium and phosphate from the solution. Ectopic ossification is an abnormal calcification of tissue. It can happen in the lungs, the brain, the eye, muscle, tendon, or even in an artery, where it might lead to arterial sclerosis. Calculus is a calcified mass in an otherwise soft organ. Mineral reabsorption is the process of dissolving bone, which releases minerals into the blood. It's performed by the osteoclast at the ruffled border. They have hydrogen pumps in their membranes that secrete hydrogen into the space between the osteoclast and the bone surface. That chloride ions would then follow because of electrical attraction, creating hydrochloric acid, which has a pH of approximately 4. In this case, will dissolve the bone minerals. There are also acid-tolerant protease enzymes that will digest the collagen. Orthodontic appliances or braces reposition teeth through the process of reabsorption and deposit. The tooth moves because the osteoclasts dissolve the bone ahead of the tooth, and bone is deposited behind it because of osteoblasts. Calcium is needed for bone structure, but it is also needed for neuron communication, muscle contraction, blood clotting, exocytosis. So minerals are deposited in the skeleton and withdrawn when they are needed for the other purposes. About 18% of skeletal calcium is exchanged with the blood every year. Normal calcium concentration in the blood is 9.2 to 10.4 milligrams per deciliter. Hypocalcemia is a calcium deficiency. Hypercalcemia is a calcium excess in the blood. Hypercalcemia is rare, but hypokalemia can result from a variety of causes. Calcium homeostasis depends on a balance between dietary intake, urinary and fecal losses, as well as the exchange between osseous tissue. Calcium homeostasis is regulated by 3 hormones: calcitriol, calcitonin, and parathyroid hormone. Calcitriol is a form of vitamin D that's produced by sequential action that take place in the skin, liver, and kidneys. First, the epidermal keratinocytes use ultraviolet radiation, convert 7-dehydrocholesterol to pre-vitamin D3. Warm sun on the skin converts this to vitamin D3. The liver would then add a hydroxyl group, converting it to calcidiol, and the kidney adds a hydroxyl group, converting that to calcitriol. And calcitriol acts to raise blood calcium in 3 different ways. It increases calcium absorption by the small intestines, it increases calcium reabsorption from the skeleton, and it weakly promotes the reabsorption of calcium in the kidneys. Calcitriol is also necessary for bone deposition. It helps provide adequate calcium and phosphate. If there's inadequate calcitriol, we get abnormal softness of bones. If that happens in children, it is referred to as rickets. In adults, it would be osteomalacia. Calcitonin is produced by parafollicular cells of the thyroid gland. They're secreted when calcium levels are too high. It lowers blood calcium concentrations in two ways. It inhibits osteoclasts and it stimulates osteoblasts. It may have a more important role in children, but in adults it has a very weak role. Osteoclasts are more active in children due to faster remodeling, but most of the information says that at physiological levels, calcitonin doesn't play a major role in calcium regulation, unlike the other hormone, parathyroid hormone. Parathyroid hormone is secreted by parathyroid glands on the posterior surface of the thyroid in response to low calcium. And parathyroid hormone is very important in bringing up the level of calcium in the blood. It binds to receptors on osteoblasts that stimulates the osteoclasts to reabsorb bone, promotes calcium reabsorption by the kidneys, so we lose less in our urine. It promotes the final step of calcitriol synthesis in the kidney, so it enhances calcium-raising effects of calcitriol, and it inhibits collagen synthesis by osteoblasts, which would in turn inhibit bone deposition. So we have when blood calcium is low, parathyroid hormone is released. When parathyroid hormone is released, we increase osteoclast activity, decrease osteoblast activity, reabsorb more from our urine, and excrete less calcium, more phosphate, less calcium, all of which will return blood to normal. And this pathway is extremely important, much more so than the previous one. Average adult has 500 to 800 grams of phosphorus, with 85 to 90% of that in the bone. Normal plasma concentration of phosphorus is 3.5 to 4 milligrams per deciliter. We also need phosphate for DNA, RNA, ATP, and phospholipids. Phosphate levels are not as tightly regulated as calcium levels. Calcitriol does raise phosphate levels by promoting its absorption by the small intestine, and parathyroid hormone lowers blood phosphate levels, promoting its excretion within the urine. At least 20 or more hormones, vitamins, and growth factors are going to affect osseous tissue. Bone growth is especially rapid in puberty and adolescence. We get surges of growth hormone, estrogen, or testosterone occur and promote ossification. Hormones stimulate multiplication of osteogenic cells, matrix deposition by osteoblasts, and chondrocyte multiplication and hypertrophy in metaphysis. Girls grow faster than boys and reach full height earlier. Estrogen has a stronger effect than testosterone on bone growth. Males grow for a longer time and generally taller. Anabolic steroids are going to cause growth to stop as they speed up the epiphyseal plate clothing. Orthopedics is the branch of medicine that deals with prevention and correction of injuries and disorders of the bones, joints, and muscles. Name implies its origin as a field in treating skeletal deformities in children. Includes the design of artificial joints and limbs and the treatment of athletic injuries. Orthopedics is the branch of medicine for the prevention and correction of bone disorders, joints, and muscles. Bone fractures are classified as stress or pathological fracture. A stress fracture is caused by abnormal trauma to a bone, a fall. Pathological fracture is a break in a bone that's been weakened by disease, such as bone cancer or osteoporosis, usually caused by stress that would not break a healthy bone normally. Fractures are also classified by their structural characteristics, the direction of the fracture line, non-displaced, displaced, cracked in multiple pieces, such as comminuted or green stick. Here we have a non-displaced fracture, highlighted in red. This one, the bones are out of alignment, that's displaced. Comminuted, we have some pieces here, and a green stick fracture, we have still connected on one side, a break on the other side. Uncomplicated fractures heal in about 8 to 12 weeks, longer for more complex fractures. It starts with a hematoma formation, converting to granulation tissue, a soft callus formation, which is a deposition of collagen and fibrocartilage that converts the granulation tissue to soft callus. Then a hard callus forms. The osteoblasts deposit temporary bone collar and unite the broken pieces while ossification occurs. And then finally, bone remodeling. The bone is remodeled based on the stresses that it was under. So we get the hematoma, the soft callus formation, the hard callus formation, and the bone remodeling. Closed reduction is a procedure in which the bone fragments are manipulated into their normal positions without surgery. An open reduction and internal fixation involves surgical exposure of the bone, then the use of plates, screws, or pins to realign the fragments. Fractures that take more than 2 months to heal may be treated with electrical stimulation, which seems to suppress the effects of parathyroid hormone. Here is an open reduction and internal fixation of a compound fracture of the tibial plateau. Beginning about age 40, net loss of bone mass occurs as reabsorption outpaces deposition. Contributing factors for that are your sex, your build, your ancestry, and your age. Women tend to be more affected than men. Small, light frames tend to be affected more than heavier frames. Osteopenia is a measurable decline in bone density, which may advance to osteoporosis. Osteoporosis is a severe loss of bone density in which the bones are easily fractured. Osteoporosis is commonly assessed by a bone densometry or DEXA scan. Treatment centers around drugs that stimulate bone deposition and slow reabsorption, but the best medicine is still proving to be preventive medicine, weight-bearing exercise throughout life, even into old age. Here are some bone that have been affected by osteoporosis. And that wraps up the bone tissue. Be on the lookout for Chapter 8 sometime this week.